Welcome back, everyone. And today we are going to discuss blood pressure. Before we can actually discuss blood pressure, we actually have to be able to understand each of the different types of blood vessels that we have. So we're going to start our discussion by talking about the blood vessels. So blood vessels are generally just comprised of all of the following, or some combination of the following: of smooth muscle, elastic connective tissue, fibrous connective tissue, and a thin layer of endothelial cells. You can actually see that not all blood vessels have the exact same components. So if you look at the artery consists of all layers. It has endothelium, it has elastic tissue, smooth muscle, and fibrous tissue. If we look at the capillary, it only has endothelium. And what we will notice is that actually the endothelium exists in every single blood vessel. It's actually the only component that exists in every single blood vessel. And the endothelium of a blood vessel is really just a single layer of thin cells that covers the lining of the blood vessel. So we're going to go through each type of blood vessel and talk about their components. But one thing that we need to keep in mind as we go through this section of the course is that the smooth muscle within these blood vessels can either contract or it can relax. And when this happens, the blood vessel either constricts or it dilates. And when the blood vessel constricts, it's a specific term that we use called vasoconstriction. And when it dilates, we refer to as vasodilation. And vasoconstriction narrows the lumen of the blood vessel, whereas vasodilation widens the lumen of the blood vessel. So just keep that in mind as we talk about this. Arteries are the vessels that carry blood away from the heart. They have an extremely thick layer of smooth muscle. They have an extremely thick layer of elastic tissue, and they have a relatively thick layer of fibrous tissue as well. They also have an endothelial lining. If you've ever looked at an artery in an anatomy lab, compared to something like a vein, arteries have quite a bit of substance to them. They are quite tubular, they maintain their shape very well, and that's a function of the elastic tissue, the smooth muscle, and the fibrous tissue. These vessels are fairly stiff, but they have fairly springy walls. They can expand because of the elastic tissue, but then they can also recoil back. And that's really important because there's quite high pressure in the blood that flows through them. So the ability to stretch is essential. And part of the function of that stretching and recoiling back is to make sure that you can propel the blood from one part of the arterial system to the next part of the arterial system. And so as arteries get further and further away from the heart, the arteries divide into smaller and smaller and smaller blood vessels. Eventually, there's no more elastic tissue. It decreases to the point that there's none. And eventually the amount of fibrous tissue that's around the blood vessels goes away as well. And you're just left with a layer of smooth muscle and a layer of endothelium. And when that happens, this is referred to as an arteriole. And so the arterioles, because they have that smooth muscle only, the vasoconstriction that happens in them and the vasodilation that happens in them really helps coordinate blood flow in different parts of the body. You can imagine that one area of arterioles can be constricted and blood would have a lot of trouble flowing through there. So it'll be redirected to another area of the body. So arterioles really help coordinate blood flow in the body. They also do other things, but they help coordinate the blood flow. Eventually, these arterioles get smaller and smaller. The amount of smooth muscle disappears, and you're just left with a single layer of cells. And these are very flat cells. And that's all that exists within a capillary for the most part. And that very thin layer of cells allows it to exchange nutrients and oxygen with the tissues of the body. Not all capillaries in every part of the body are going to exchange nutrients to the exact same extent. Some capillaries are quite a bit more leaky than others. And the determining factor as to whether they are leaky or not is the presence of these special cells called pericytes. Peri just means around, and so there's cells that are around the capillaries. The more pericytes that a capillary has, the less leaky it is. So something like the blood-brain barrier, which would be between the cerebrospinal fluid and the blood in the brain and spinal cord, there's going to be very little exchange because those capillaries have quite a bit of pericytes. Compared to something like the kidney, where you want a lot of exchange, you want a lot of leakiness because you need to filter the blood, and so the capillaries that are within the kidney are going to be quite leaky, and they're going to have less pericytes. As blood makes its journey back to the heart, eventually those capillaries are going to join together, and eventually you're going to get a little bit of a return of that fibrous tissue. And so those larger vessels are going to have a bit of fibrous tissue and an endothelial lining. And when you have a bit of fibrous tissue with endothelium, that type of vessel is called a venule. The smallest venules of the body can also participate in exchange with the tissues, just like capillaries, because they're thin enough. But as the vessels get closer to the heart, they get larger and larger. Eventually, they turn into veins. And you'll see that the composition of a vein looks similar to the composition of an artery. There's just less of everything. There's less elastic tissue. There's less smooth muscle. There's less fibrous tissue. And these vessels, if you've ever seen them in an anatomy lab, they don't hold their shape very well. They tend to be very flimsy and floppy. They don't look like tubes. Sometimes they're completely flattened. And veins tend to act, rather than holding on to the pressure of the blood, they tend to hold on to the volume of the blood very well. And they're sometimes referred to as volume reservoirs. There's quite a low pressure in the veins. So the question is, how does the blood actually go back to the heart if there's no pressure driving it back to the heart? And the answer to that is that there are valves and skeletal muscle. And so if we look at the large veins of the lower limb, we'll see that there are the muscles of the calf, and these large veins have valves, and they only open in one direction. So blood can only flow from the distal part of this limb toward the heart. It cannot flow backwards because these valves don't open backwards. And the way that we actually propel the blood forward is, imagine that you have blood in the ankle and foot. Well, when the muscles around the ankle and the foot contract, they're going to compress those veins and push all the blood back or forward into where the calf is. When the muscles of the calf contract, they're going to compress the vein, and all the blood is going to be pushed forward into the thigh. When the thigh muscles contract, it's going to push the blood into the abdomen. When the abdominal muscles contract and the organs contract around them, and the pressure increases in your abdomen, it's going to push the blood back to the heart. So it's this constant compression of the veins that is going to allow for the blood to flow back. Essentially, we have two separate functions within the heart. We have the right side and we have the left side, and each functions very differently. If we look at the left side, this is more the side where the arteries are, and it's a more elastic system that will act as that pressure reservoir and allows for there to be a maintenance of blood flow so that you can propel the blood forward to the distant parts of the body. Eventually you reach the arterioles, And they're represented by these screws on the outside, and they're adjustable screws. So imagine that this first area of arterioles, imagine that this area is, the screws are wound up, and it compresses this arterial system. Blood's going to have a hard time going through there, and it's going to be redirected to the areas that are open. So the diameter can change. The more open it is, the more blood that is going to go through. And eventually it reaches the capillaries, where you're going to get that exchange via diffusion between the cells and the capillaries. Then once that exchange is done, you start going into the venous system, or the venous system. And this system acts more as that volume reservoir. It holds on to large volumes of blood and gets pushed back to the right side of the heart via skeletal muscles. And so think of it like two pumps and two separate systems. The arterial side is a pressure reservoir, and the venous side is a volume reservoir. So now we'll talk a little bit about blood pressure. So the main force that actually that's creating blood flow in the body is ventricular contraction. So there's very high pressure blood that's ejected from the left ventricle into the aorta and the large arteries. And those large arteries can store the blood very temporarily. It's because that blood goes into them. That elastic tissue allows those arteries to expand and hold on to the blood. But eventually that elastic tissue is going to recoil back. When the elastic tissue recoils back, it propels the blood forward into the more distal regions, eventually getting to the level of the capillaries and each individual tissue. So the first thing that happens to create blood pressure is that the ventricle contracts. Blood goes past the semilunar valve. If this is the left side, it's the aortic valve. And blood is ejected into the large arteries. And those large arteries expand. They expand because the elastic tissue in the walls of those vessels will temporarily hold on to the blood. The ventricle then relaxes, and the semilunar valve closes, but that blood that's now in that artery is going to get propelled forward because now that elastic tissue recoils back and pushes the blood forward into the rest of the circulatory system. So if we look at pressure differences across the entire circulatory system, pressure is definitely highest in the arteries compared to the veins. But this pressure continuously decreases as you go throughout the circulatory system. And the reason that the pressure decreases is because there is a loss of energy in the circuit. That loss of energy comes from two places. Number one, it comes from the resistance to flow in the vessels. So as the vessels get smaller and smaller, the ability to have blood flow through them goes down. Energy is also lost because as you're pushing the blood forward, blood cells are rubbing on each other. And that friction between them causes energy to be lost. So friction between the blood cells and the smaller diameter of the blood vessels causes there to be an energy loss and pressure to decrease. So if we look at a chart of the pressure in millimeters of mercury across each section of the circulatory system, start in the left ventricle. During relaxation or diastole, that pressure is very low, only a few millimeters of mercury. During contraction, that pressure goes way up. It goes up to almost 120 in normal circumstances. And so that's during systole. The left ventricle relaxes and contracts. And so there's this pressure wave as it contracts and relaxes. If we move to the artery side of things, during ventricular contraction, blood is ejected into the artery. And that pressure of the blood in there is the same as that top pressure in the left ventricle. So during systole, your pressure in your artery reaches a certain level. And so that's during systole, you reach a certain level. And in this diagram, that is 120 millimeters. Because it's during systole, we refer to that as the systolic blood pressure. Well, when the pressure in the ventricle decreases, those elastic fibers are recoiling and propelling blood forward. The pressure in that artery goes down. It never quite goes down as low as the ventricle. At the very base of diastole, the pressure in the artery only goes down to about 80 millimeters of mercury. It doesn't go all the way down. If you need a refresher on looking at the pressure in an artery, you can look at that diagram from the previous lecture where we looked at aortic pressure, and you'll see that it doesn't go much below 85 or 90 in that diagram. And so because this pressure is during the diastolic phase, that lower pressure is referred to as the diastolic pressure. And so pressure stays fairly high within the arterial circuit. And so in this case, it's 80. So you have a systolic blood pressure and you have a diastolic blood pressure, and they're different values. So 120 versus 80. Eventually, because of the friction between the blood cells, eventually those blood vessels are getting narrower and narrower as you go into the arterial system. Now we're into the arterial system. More and more blood vessels that are narrower and narrower, you're having loss of energy and you lose that pressure wave. Eventually, once you get to the capillaries, you have such resistance to flow and such loss of energy from the friction between the cells that rather than this pulsatile movement of blood, it's more of just a constant, steady flow. So this is one of the reasons why if you ever get a laceration and if somebody cuts an artery, that blood is actually going to squirt out with every single heartbeat. Compared to if they just cut a few capillaries or a vein, it's a steady flow. You still could lose a lot of blood through a vein, but rather than a pulsatile flow, it's going to be a steady ooze rather than a pulsatile flow, because you don't get the changes in the pressure with each beat, because we've lost so much energy in the circuit that you don't have that pressure wave anymore. There is a name for this, the difference between systolic pressure and diastolic pressure. There's a name for what the difference between those two values is and the magnitude of this pressure wave in the arteries. And it's called the pulse pressure. And what the pulse pressure tells you is how strong of a pressure wave do you have. So if the systolic blood pressure is very high and the diastolic blood pressure is very low, you're going to have a really high wave. And the pulse pressure is a lot higher. Compared to if you have the systolic blood pressure is very close to the diastolic blood pressure, you'll have a very tiny wave. And that wave, you can imagine, would dissipate out very quickly. When we talk about blood pressure in a healthcare setting, we often talk about it with two numbers. And so those numbers might be 120 for the top number and 80 as the bottom number. And the way that we state this is we write it like a fraction and we state it as 120 over 80. And so that tells us systolic blood pressure over diastolic blood pressure. We can measure blood pressure too, and we use a device, a blood pressure cuff called a sphygmomanometer, and so it measures the pressure within the arteries. We often measure blood pressure on one of the larger arteries of the limbs. So most commonly, it's in the artery of the upper limb, which is in the upper arm, which is the brachial artery. And so this blood pressure cuff, it has a balloon inside, and when you pump the pressure cuff up, it increases the amount of air in the balloon. And that, when it's around your arm, will increase the pressure around your arm. And so what we really want to do is we want to figure out systolic blood pressure and diastolic blood pressure. Where's the blood pressure the highest and where's the blood pressure the lowest? So we have to figure out how much pressure do we need to put in order to figure out exactly when that artery is shut, is compressed by that pressure. Because if the pressure is higher in this cuff, it's going to completely block off the flow of this artery. And so we want to know what that value is. So the way that we find that value is we look at one of the arteries in the wrist. So in order to figure out how high do we pump this pressure gauge up, we pump up the pressure gauge while we feel for a pulse in the wrist. And we specifically feel at the radial pulse, which is on the side of the thumb. So we feel on that pulse, and as we pump up this pressure cuff, we're eventually going to come to a point where we've compressed the brachial artery. If we've compressed the brachial artery, we're going to have no blood flow going through here, and we won't feel the pulse anymore. So we figure out exactly when we stop feeling the radial pulse, and then the textbooks, when you're measuring blood pressure, they say, pump it up another 30 millimeters of mercury, because this is all on millimeters of mercury. And then once you do that, you put your stethoscope where you'd expect to feel there's a pulse in your arm called the brachial pulse. It's right at just above your elbow joint and between the two heads of the bicep muscle. You put your stethoscope there and you listen. And you very slowly start to decrease the pressure in the cuff. So there's air leaving the cuff, the balloon of the cuff, and there's less pressure on the arm. Eventually, there is a time when the pressure in the cuff is exactly equal to the pressure in the artery. And so when that happens, we still can't feel anything. We can't actually, there's nothing that's happening because the artery is still compressed. But the moment the pressure in the cuff goes just below the pressure in the artery, that artery opens up the slightest bit during that high phase of the blood pressure. That highest phase of the blood pressure, that artery is going to open up the slightest bit. And when the artery opens up the slightest bit, small amounts of blood are going to hit the arterial wall with quite a bit of force. And you're actually going to hear that with the stethoscope. You're going to hear little bits of blood hit the arterial wall. The moment you hear that first bit of blood hit the arterial wall, if you look at your blood pressure cuff, that is your systolic blood pressure. That is the highest pressure that you have in your artery. And that particular sound that you hear is something called a Karot cough sound. And so you listen for what they refer to as the first Karot cough sound. That very first sound you hear is exactly the systolic blood pressure. And so then you continue to deflate the blood pressure cuff, continue to go down. You're still going to hear Karot cough sounds, but eventually that artery opens up and opens up and opens up, and eventually it's opened up fully. And the interesting thing is, once an artery is opened up completely, the flow of blood through that artery makes absolutely no sound. Even though your stethoscope is on an area where there's a literal pulse there, you can actually feel a pulse, you won't hear any sound if that artery is completely opened up. So as you're deflating, those sounds that you hear in your stethoscope are going to get fainter and fainter and fainter until you don't hear them anymore. The moment you stop hearing the Karot cough sounds, that is your diastolic blood pressure. So once the Karot cough sounds disappear, you got diastolic blood pressure. It's not the best or most accurate measurement of blood pressure anymore. We tend not to use this method. We tend to use an automated method. If you've gone to your family doctor's office and they've checked your blood pressure, you'll know that you're often left in a room on your own. The blood pressure cuff goes up 6 times. What that automated method does is it throws out the highest reading, and then it averages the other ones. And then it gives you an average blood pressure over several readings. It's more accurate. But in a bind, or when you don't have one of those, or if a doctor's office doesn't have one of those, which they should, they can use this type of blood pressure cuff. Normal blood pressure is somewhere around the systolic of less than 140 and a diastolic of less than 90 under regular circumstances. Some people need a blood pressure that is actually a bit lower than that. In terms of low blood pressure, in general, if someone doesn't have symptoms, that might be a normal blood pressure for them. If they're not lightheaded, they're not passing out. Some people might say, oh, I have very low blood pressure. And it's generally not a problem unless you actually have symptoms with it. So we're going to now talk about how does blood pressure change, and what are the factors that change blood pressure? And so in order to do that, we've talked about how blood pressure is represented with two numbers, but that's actually not quite helpful, because the real question is, what number do we use? Which number is more important? Is the top number more important, or is the bottom number more important? And the answer is that both are equally important. And so it's actually quite useful for us to represent blood pressure as a single value. And we can do that by getting the average of the two numbers. And so we refer to this as mean arterial pressure. So when we talk about blood pressure in this course, from now on, unless I'm getting you to calculate the mean arterial pressure, I'm going to talk about blood pressure as a single value, or I want you to start thinking about it like a single value. And so the way that we calculate mean arterial pressure is we take the diastolic blood pressure and we multiply it by 2/3, and we add it to the systolic blood pressure times 1/3. So we take 2/3 of the value of the diastolic and we add it to 1/3 of the value of the systolic. And what this does is it gives you a single value that's an average of the two, and it represents the driving pressure of the blood. How well is blood flowing through the circulatory system? We calculated the strength of the pressure wave with the pulse pressure, but this is more about how well blood flows through the circulatory system. And so you might be thinking, well, I told you they're equally important. So why is it not 1/2 of the diastolic and 1/2 of the systolic? And the reason for that is that our relaxation phase of the heart is twice as long as the systolic phase. And so that diastolic blood pressure accounts for 2/3 of the average value. And the systolic blood pressure only accounts for 1/3 of it, because we are in diastole twice as long as we are in systole. So that's why you're getting 2/3 and 1/3. So if we think about now what are the determinants of mean arterial pressure, we're looking at mean arterial pressure is the driving force of the flow of blood. And it is a balance of two values. Number one, it's a balance of how much blood is flowing into the arteries compared to how much blood is flowing out of the arteries and into the arterioles and the capillaries. If you have more blood flowing into the arteries than is flowing out, the overall mean arterial pressure is going to increase. If this was reversed and you had more blood flowing out than is flowing in, your mean arterial pressure is going to decrease. And the blood flowing into the arteries depends on the cardiac output, how much blood is being pumped out of the heart per unit time. And the flow out of the arteries is largely dependent on the resistance within those smaller vessels, those arterioles. If all of those arterioles are really constricted, less blood is going to be able to flow through them. So you're going to end up with more blood in the arteries, which is going to increase mean arterial pressure. So in other words, anything that changes flow into the arteries or cardiac output will change the mean arterial pressure, and anything that changes the flow out of the arteries or the resistance in the arterioles will change the mean arterial pressure. So these are the two big determinants of mean arterial pressure. Mean arterial pressure varies directly with the cardiac output and the resistance in the arterioles. And so if you don't believe me, which I'm sure some of you are probably screaming at your screen and they're like, no, we believe you, we believe you. But I am going to talk about this in terms of a bit of mathematics. And now you're really screaming at your screen because maybe you don't want to talk about math. I'll never get you to prove this, but I want to show you that this is actually a thing, that the mean arterial pressure varying directly with cardiac output and resistance in the arterioles is actually a sound mathematical relationship. And so I'm going to share my little whiteboard with you, and we're going to talk about this. So we know that mean arterial pressure is going to vary with cardiac output and the resistance in the arterioles. So this is flow in, this is flow out. Okay. So there's a physics relationship when we talk about fluid dynamics, the flow of fluids in systems, particularly cylindrical systems or tubular systems. There's a law that states that the flow through a circuit, or flow is sometimes just denoted Q, is equal to the change in the pressure across the end of the circuit compared to the beginning of the circuit, divided by the resistance across that circuit. So this is the relationship that we have to start with because this is a well-known physical law. And so this is telling us that if we have this tubular system where we have, and I guess the delta P is just the difference in the pressures. So it's pressure 2 minus pressure 1, the beginning versus the end. So if we have pressure 2, this is going to be the highest pressure that you have. And in our circulatory system, the highest pressure we have is the pressure that's coming right out of the left ventricle. So we have our pressure in we'll say the aorta, compared to the pressure at the very end of the circuit, which is the pressure in the large veins that are returning blood to the heart, or the pressure in, we'll say, the right atrium. Or the central veins. And so this is where it becomes very useful to talk about the pressure, the blood pressure, as a function of one number. So if we were to just describe the pressure in the aorta as a single value, we know there's a systolic blood pressure because this is what the pressure in the aorta is going to look like. There's a systolic blood pressure, there's a diastolic blood pressure. But if we want to represent both of these as a single value, that's where our mean arterial pressure comes from. So we can say that this pressure 2 is really just mean arterial pressure. And so that takes care of P2. So we know exactly what P2 is. P1, which is the pressure at the end, you kind of have to know what is the pressure in those central veins and just leading into the right atrium. In a normal person, it might be a millimeter of mercury. So for our purposes, we're actually just going to say that this pressure is essentially 0 millimeters of mercury. 0. So if we sub these values into the overall equation of flow, we get delta P is, so Q, which is flow, equals P2 minus P1 divided by R, which is resistance. So now we can sub in these values in each here, and we will have Q equals mean arterial pressure minus 0 divided by R. And so that 0 just goes away, and we have Q equals mean arterial pressure divided by resistance. And I'm going to write out resistance. When we talk about resistance, we're talking about the resistance to flow out of that system. In our circulatory system, that resistance comes from the arterioles. So we're almost there. It might not be looking like the relationship at the very top yet, but it's almost there. So now we have to figure out what physiologic value can we put in for the flow. The flow of the blood, how much, the flow is just Q. Q is really just a volume of something per unit time. Usually it's per minute. So maybe liters per minute. And if you think of your values that we've learned so far that is in liters per minute, that's our cardiac output. How much blood is flowing per unit time. So in place of Q, we can just say that Q equals cardiac output. So we can sub in cardiac output for this. So we know cardiac output is equal to the mean arterial pressure divided by the resistance in the arterioles. And all you got to do is just a little bit of algebra. You need to cross multiply. And what we're left with is the relationship that mean arterial pressure equals cardiac output times resistance in the arterioles, which is exactly the relationship that we have in our slide. Mean arterial pressure varies directly with cardiac output and varies directly with resistance in the arterioles. So that's the mathematical proof, if you were interested. And some of you might not be interested, but it helps it make sense if you're a mathematical type person. If you're not, I won't ever get you to prove this on a test or anything like that, but it's good to kind of know. So I'm going to go back to the previous screen. So now we know where this formula comes from. But now we can look at different changes in different factors here. So what will happen to the mean arterial pressure? So here's an example. If our blood volume changes, well, our blood volume can be determined by fluid intake. If we increase our fluid intake, we're going to absorb all that fluid through our GI tract, and there's going to be more fluid in our blood. Our blood volume is going to increase. So the amount of blood that you're going to pump per unit time goes up. So that increases your cardiac output. And if you increase cardiac output, you increase mean arterial pressure. So more fluid intake means that you're going to increase pressure. If you end up losing a lot of fluid, you have less fluid in your blood, less blood is going to be pumped out of the heart per unit time, so your cardiac output goes down. If your cardiac output goes down, your mean arterial pressure goes down. And so one of the first things we do if somebody comes in and their blood pressure is really low is we give them fluids. We resuscitate them with fluids. We give them an IV and we pump in fluids because we know that that is going to bring their blood pressure up. So if we think about now the effectiveness of the heart as a pump, okay. Well, how well is the heart pumping? Say, what happens if we increase heart rate? Well, we know that cardiac output is a function of heart rate times stroke volume. If we increase our heart rate, we're increasing the amount of blood that is being pumped out of our heart per unit time. So our cardiac output goes up and our mean arterial pressure goes up. Another example would be stroke volume. Say that the opposite thing is happening to stroke volume. These are all just examples. These arrows I can give you any example. I can say stroke volume increases or heart rate decreases. And you should be able to tell me what would happen to mean arterial pressure from a sort of logical explanation standpoint. But in this example, we have low stroke volume. This is just the example I'm giving. So low stroke, we have a lower stroke volume. That means less volume of blood per beat, which means that less blood overall per minute is going to be ejected from the heart. So our cardiac output goes down and our mean arterial pressure goes down. So I can give you any scenario. I can say, what would happen to mean arterial pressure if heart rate went down? Well, you should tell me, well, lower heart rate, less beats per minute. So that means the amount of blood that's going to flow out of the heart per minute is going to go down. And that means our mean arterial pressure goes down. The last factor here, which is just the resistance to blood flow, is determined by the diameter of the arterioles. And so say that we have an increase in diameter of the arterioles. So those little tiny vessels, these are not the arteries, these are the arterioles. If that diameter increases, more blood is going to flow into them and is going to flow out of the arteries. So more blood flow is going to come out of the arteries, and you're going to decrease the mean arterial pressure. So increasing the diameter of the arterioles decreases the resistance in the arterioles. And I can give you any example of that. The resistance in the arterioles is actually determined by something called Poiseuille's law. Really important physiologic concept. This is going to come back in our respiratory section. It's extremely important. The resistance to flow, what this states is that the resistance to a flow of a fluid varies. So the resistance to flow varies with the length of the vessel you're talking about. It varies with that symbol is mu in the Greek alphabet. So, and that often represents viscosity. So how thick is the fluid? So this would be the viscosity of the blood, divided by the radius of the blood vessel. And this is an important one because it's not just a linear relationship here. Yes, length is linear. Yes, viscosity is linear, but the resistance to flow is a relationship to the exponent 4. And so that's going to come into play when we try to determine what's happening when these arterioles are vasoconstricting and vasodilating. If we think about the human body, the length of your blood vessels, you're not going to change the length of your blood vessels. That's constant. And in a normal circumstance, the viscosity of your blood is constant. We're not talking about disease states. Viscosity of your blood, constant. So the only thing that is going to affect the resistance to flow through your arterioles is the radius of the vessel. That is the primary factor that determines the resistance to flow. And so we can state this relationship by resistance varies, and this is an inverse relationship. It varies inversely with radius, but it's to the power of 4. So if we put this into perspective, if we reduce the radius by a factor, like if we reduce the radius, if we cut it in half, if we cut the radius in half, well, that is actually going to change the resistance to flow by a factor of 16. So we have 1/2, but it's raised to the exponent 4, which would give you 1/16, meaning that there's 16 times the resistance to flow. So something with a smaller radius, so a radius cut in half, a tube with that radius cut in half is actually going to have 16 times harder time flowing through that circuit. So, so very small changes in radius can lead to huge changes in the resistance to flow. And if we look at the relationship, the higher the resistance, the lower the flow. So flow and resistance are inversely proportional to each other. If you have a very low resistance, you're going to have a very high flow. You have a very high resistance, you're going to have a very low flow. And so we can look at an example here. If you have a container of water and you have a tube system, imagine you have this tube system with a radius of 1. We're going to say radius of this tube is 1. The amount of volume you get out is 1. So if the I know there's no units here, but we'll just say it's 1 liter. 1 liter of fluid of water comes out. If you have in the same circuit, you actually have a tube that has double the radius. The amount of fluid that comes out is actually 16 liters. So doubling the radius causes the fluid, the flow, to change by a factor of 16, or 2 to the exponent 4. So simply doubling the radius will have a huge change in the amount of flow that can go through that system. And so what really affects the radius of the arterioles? There's a few things. Sympathetic input changes the radius of the arterioles. Local hormones will also affect the radius of the arterioles. And things that are released at what they refer to as local control at the level of the tissue. So from the cells of the arterioles, some substances will cause that particular arteriole to dilate. It'll be a substance that's produced by the endothelial cells of that arteriole, or in the tissues around that arteriole. Will secrete something that will change the radius. So local control, several molecules that are released by the vascular endothelium affects whether that arteriole will constrict or dilate. One of these molecules is carbon dioxide. The more carbon dioxide that's produced, the more those arterioles are going to dilate. And so if you think about it, carbon dioxide is released as a byproduct of metabolism. So if you have increased metabolism in a tissue, you generally need more oxygen to get to that tissue. And so as a result, the carbon dioxide is going to cause the arterioles to dilate. And if they dilate, more blood flow can go to that tissue. And if more blood flow goes to that tissue, you get better oxygenation of that tissue. There are other molecules that will dilate arterioles. Two of them are something called bradykinin, which you may not have heard of before, but that dilates the arterioles. It's released in the inflammatory response, or sometimes a pseudo-allergic response. So if someone has sort of an area of inflammation, that area is often red. And that red is an increased blood flow to that area because the arterioles have dilated and have allowed more blood to go there. And that could be the direct effect of bradykinin. Histamine is also another substance that will dilate the arterioles. Another molecule that's produced locally is something called nitric oxide. It's released in many situations, but it is a substance that will dilate the arterioles, allow for more flow out of the arteries. So all of these substances would increase flow out of the arteries and would decrease mean arterial pressure. Molecules that constrict the arterioles, serotonin is one of them. The last two we're going to talk about later. Angiotensin. Angio is a prefix that means blood vessel, and tensin means it tenses the blood vessel, so it constricts, vasoconstricts. Similarly, vaso also means blood vessel, and press means to constrict. So it compresses, it vasopresses the arterioles. We're going to cover this in the kidney section. But all of these molecules would constrict the arterioles. And in that situation, you're going to have an increased resistance to flow through the arteriole, meaning that less blood can get out of the arteries. Well, there's less blood flowing out of the arteries. And less blood flowing out of the arteries means that you're going to increase your mean arterial pressure. The majority of the time, our arterioles are actually going to change their resistance by sympathetic control, or the fight or flight response. Our arterioles actually have adrenergic receptors in them. Exactly the similar type of adrenergic receptors that you actually find in the heart. Some of those types of adrenergic receptors are actually found in some of the blood vessels. And these receptors are activated by norepinephrine or adrenaline. Some arteries have those beta receptors that we talked about. And in general, those arterioles that have beta receptors in them will cause vasodilation, will actually have more blood flow to the tissue. And some arterioles have alpha receptors, which is a type of receptor we haven't talked about yet. And alpha receptors in general, those arterioles that have alpha receptors cause vasoconstriction. The way I remember alpha causes vasoconstriction is I sort of think about the alpha sign as being like a rope that's tied around the vessel. And if you pull on the ends of the rope, that space on the inside of the alpha sign gets smaller. And I think of that being the vessel, and it actually constricts the blood vessel. So alpha activation of an alpha receptor will generally cause constriction of arterioles. And so I said some arterioles have beta receptors, some arterioles have alpha receptors. In general, the arterioles that have beta receptors that are going to allow for more blood flow to get to the tissue are those that are in the liver, the blood vessels around the heart or the coronary vessels, and the blood vessels that are in skeletal muscle. And if you think about it, you do want more blood flow to go there during times of fight or flight. So the liver will get more blood flow so that it can actually make more glucose and carry more glucose to the areas of the body that need energy for the fight or flight response, so that you can swim away from the shark. The heart needs more oxygenated blood so that it can pump more blood to the muscles that need to work to get away from the shark. Your skeletal muscles are also going to are going to vasodilate because your skeletal muscle needs more oxygen so that you can swim for a longer period of time away from that shark. In general, everything else has alpha receptors, and it's going to cause the arterioles to vasoconstrict, and less blood is actually going to go to the tissues that are associated with those arterioles. So like the GI tract, you're going to reduce blood flow to anything that isn't essential. So think of it like that, to determine which of these arterioles have beta receptors, which of the arterioles have alpha receptors. Think of it like that. Everything else is alpha receptors. But beta receptors are in the organs where you actually need blood flow in order to carry out the fight or flight response. So, factors affecting blood flow. Here we go. There is that pressure gradient. So remember that math formula that I wrote out, where you have mean arterial pressure at one end of the tube minus that right atrial pressure, which I said was 0. So at the other end of the tube. So we're left with just mean arterial pressure being a factor that is important in blood flow. And we talked about how mean arterial pressure is very important when is determined by how much blood volume do we have. So the total volume of blood, the higher the blood volume, the higher the amount of blood that's actually going to flow into the arteries. And so that's going to be a determinant of the mean arterial pressure. But then we talked about the flow of blood into the arteries compared to the flow out of the arteries. And the blood that's actually flowing into the arteries is determined by the cardiac output. The more blood that's flowing in, the higher the mean arterial pressure. If there's less blood flowing in, or there's less cardiac output, your mean arterial pressure decreases. But we can't forget that cardiac output is determined by the heart rate and the stroke volume. So anything that affects the heart rate will affect the cardiac output, and anything that affects the cardiac output will affect the mean arterial pressure. So there's a multi-level layers, there's multiple layers to look at when we're discussing, when you discuss factors that affect blood flow and factors that affect mean arterial pressure. So I could tell you, I could ask you the question, what would happen if the heart rate decreases? What would happen to the mean arterial pressure? And you should be able to tell me, well, if heart rate decreases, that means that the cardiac output is going to decrease. And if the cardiac output decreases, I know that the mean arterial pressure decreases. So you should be able to work backward from this. This is a really good chart and diagram. Same thing with the stroke volume. Stroke volume affects the cardiac output, which will affect the mean arterial pressure. The other thing that affects mean arterial pressure is the flow out of the arteries, which is generally determined by the resistance in the arterioles. And we talked about the resistance to flow in the arterioles is determined by that Poiseuille's law. And we talked about how the length is not going to change in a normal setting. The viscosity of the blood is not going to change in a normal setting. And the only thing that will change is the radius of the arteriole. So, and that change can either be from the sympathetic nervous system, so a reflex control in the sympathetic nervous system with adrenaline and noradrenaline, or it can also be affected by that local control. So those substances like serotonin and nitric oxide and bradykinin and histamine, those things can change the radius of the vessels, which will change the resistance to flow. Just don't ever forget that the radius is to the power 4. Tiny changes in radius will have huge changes in the resistance to flow. Okay, so that is the section on blood pressure. We'll stop there for today, and just make sure that you go through those charts and understand those charts and really figure out every possibility of changing in one factor and what it will do to the mean arterial pressure. I don't expect you to memorize every single scenario. I want you to understand every scenario so that you don't have to memorize it.